welcome Dr. Spock.
Well, thanks, guys. Appreciate the invite. I was so fortunate to meet you guys at YoMed, and our paths followed along pretty closely there for a while. I thought I was maybe destined to be a plastic surgeon. We were doing our research together with Dr. Deepak Narayan. God bless him, rest his soul. But we had some great times, some research trips to Thailand there, and then ultimately our paths diverged a little bit. I kind of sort of felt like the surgical dermatology route was just going to be a better match and fit for me, and so I bid farewell to the plastic surgery community and kind of moved over to the dermatology side of things. Like Matt said, I was down at University of Miami for my residency, which is very procedural, very hands-on residency program, working out of University of Miami, Jackson Memorial, Mount Sinai, Miami Beach. And then from there, I went and got some additional training out in California, where our paths kind of crossed again. I think Matt was out there at the Bunkie Clinic, and I was out at California Skin Institute, working under Greg Morgenroth for a year, learning some additional reconstructive techniques, some cosmetic derm stuff. And then I relocated back here to sunny Florida in 2014. And I've been with Water's Edge Dermatology since then, which has grown from, I think when I joined, they had maybe 15 offices. And now, through a combination of mergers with River Chase Dermatology and a few other practices, even as far north as in Georgia and as far west as Alabama, I think we're well over 150 offices at this point. But my focus, as they've said, is skin cancer. I'm a board certified dermatologist and board certified Mohs surgeon, and I think we're really a skin cancer hotbed down here in South Florida. So all ages, from as young. I think the youngest patient I treated with a skin cancer was probably 17, and then we have patients all the way up into their 90s and hundreds who are still growing. Some pretty aggressive skin cancers and need that stuff dealt with. So I'm looking forward to chatting a little bit about, the importance of sun protection, things that you can do to minimize risk. And then maybe, we can talk a little bit about common skin cancers, diagnosis, some common treatment things, and even some newer things that are out there in terms of maybe diagnostics or prognostic things that the patients may not be aware of, things that their doctors may not even be aware of, that they should be asking about, good questions to ask just to kind of help, risk stratify where they may fall when you're given a diagnosis of skin cancer. So, looking forward to getting into some stuff. What do you think we should do to start it off here?
No, for sure. And, Chris, it's great. Whenever I always joke that whenever Matt and I or I call you, I always come away with something. So this is going to be great to focus in on some of your areas of expertise here. I mean, yeah, skin cancer really it affects everyone, right? It affects us all. So it's amazing. Yeah, it's a really important topic. It is the most common cancer worldwide. So the number one is skin cancer. And I guess we'll go over, non-melanoma versus melanoma, but maybe we can start out with just about sun protection, Dr. Spock. What do you, in terms of, we talk about it obviously with our patients in terms of the importance for post-surgical scarring, but what are you looking for in sun protection? Like sunscreen, supplements, what kind of stuff can you touch on there? Specifically, like post-operative stuff with scars was for sun protection as well.
We always try to keep it simple. I mean, you go to the sunscreen shelves in the drugstore, and I mean, there's hundreds of choices. So we always try to tell our patients, listen, you want at least an SPF 30 or higher. You want something that's broad spectrum, and preferably you want something that's a mineral-based sunscreen. So you want to use zinc oxide or titanium dioxide sunscreen. You really want to stay away from the chemical sunscreens, things like the octicrylene, octisalate. Some of these things can cause skin sensitivities or photoallergic problems in the sun. A lot of these things aren't really even safe for coral reefs. That being said, I always tell patients, if your choice is using a chemical sunscreen or getting a sunburn, you're still better off using the chemical sunscreen. So that's a really important, thing to stress. And probably the most important thing we stress to patients is you really want to avoid sunburns. There's something uniquely bad that happens kind of at the DNA level when you go out in the sun and you get a sunburn. And, like one sunburn is much worse than just kind of many days in the sun where you don't burn. There is sort of a cascade that's triggered at the cellular level that really sets you up for potentially skin cancer later in life. And that's a screening question we'll often ask patients. Did you ever get blistering sunburns when you were younger? Those sorts of exposures are really quite dangerous for the skin. So I think the number one rule is don't get a sunburn. So whether that means just your zinc sunscreen, or especially we're big fans of sun protective clothing down here. You want to get something that's going to give you sort of a UPF or sun protection factor that you can just wear. That's actually my preference down here. I have a lot of these clothes that might have, they're pretty lightweight, they're breathable. You can put up a hood or something like that with it and really protect yourself from the sun. With regard to post-surgical scarring, we actually sell quite a bit of Silogen scar gel, which they make a formulation that has the sun protection factor in it. It's a zinc oxide for daytime use, and that's a great product. Patients can be putting on a scar if they're anticipating being out in the sun for any extended period of time. But I mean, sun protection clothing is really the key. A lot of people, they put their sunscreen on and then they go out the whole day and they never put it back on. So you got to remember to reapply if you're going to be out there. The sun protective clothing kind of gets around that and lets you stay out longer and not have to worry about, reapplying if you're out on the boat and you forgot your sunscreen or something like that.
Just a quick question about the chemical sunscreens. So the concerns, obviously, like, is there legitimate concerns in terms of like absorption into the body and impacting on like hormones, et cetera? Like, is there?
That seemed to be hot back a couple of years back, right? Yeah, they're talking about that.
I don't know all the studies on that. I mean, there may certainly be something to that. I think the more common thing we do see, though, is really skin sensitivities to a lot of these chemical sunscreens that people think they're doing a good thing. They're putting it on. And a lot of people end up getting some kind of, contact dermatitis or some kind of skin irritation. Patients have underlying rosacea. A lot of these chemical sunscreens can actually exacerbate their rosacea or other inflammatory dermatoses. So I think as a rule, it's just best to kind of stay away from them. We're going to have a new sunscreen agent that just got approved by the FDA that's been available in Europe. And so I'm still kind of waiting to see some of the data on that and where that's going to fit in the scheme of things. But, that may be something else in our toolkit as we think about sun protection.
So I just wanted one more follow-up just in terms of the mineral sunscreens. Have you seen a lot of sensitivity with people with mineral-based sunscreens, or are there more options now where people aren't getting those kind of skin topical sensitivities?
It's definitely much less with the mineral-based sunscreens. A lot of people don't like them because the formulations are kind of, if it's not micronized properly, it does kind of look pasty white, and a lot of people don't like that. But, a lot of the main brands now, Blue Lizard, Neutrogena, are coming out with pretty good technology to micronize it, and it actually rubs in quite easily. And a lot of these are kind of formulated, try to be fragrance-free and kind of minimize some of the other potential contact allergens you might see. So there's still a pretty broad selection out there. And I mean, off the top of my head, I mean, there's Coola brand, Blue Lizard, Neutrogena. I mean, there's a lot that are out there and available. And if you can't find it in your local store, I mean, a lot of these things sell online and you can kind of track down what you want. They even make these spray mineral sunscreens, which for a while was kind of tricky. Although the price point of those can be high. I mean, I've seen a lot of spray mineral sunscreens retail for 40 or 50 USD. So again, the sun protective clothing sometimes is the way to go, and then you just kind of coat the exposed areas with a little zinc oxide with whatever's sticking out.
Again, post-operatively, one of the big things that we tell our patients is just really try to keep that scar out of the sun. Right? That's that the sun will hyperpigment. Yeah. So what would you say? Would you say the first line would be then just to cover it basically with clothing?
We love to have patients, encourage them to use even some of these, whether it's a scar gel that has a zinc in it, or even some of these scar, silicone tape of some kind. Some of these have a more opaque, color to it. So it's something you could almost kind of cover that wound for that first month, post-operatively. And obviously, if it's something where they can just avoid, try to avoid that exposure, that's even going to be better. But certainly that's something that we would encourage patients to use for typically 4 to 6 weeks, post facial surgery.
Maybe the next one I'll ask you about is switch gears a little bit more to like excisions. Matthew and I have done a lot of excisions over the years, and but it's not always so simple. And often they're kind of sent to us by the dermatologists. And our only option, well, what we do is we operate, right? And we cut things out. But can you help us understand a little bit about how you decide on whether a patient's going to go for Mohs versus a more simple excision versus other topical treatments, radiation, and other therapies? How do you, because you're kind of at that intake point, right?
Sure. And I mean, there may be some differences too about, and even just kind of, just being aware, that there may be some different pathways in the Canadian system versus the U.S. system, just with access and things like that. Because down here in the States, in Florida, certainly, anyone can sort of just call up a dermatologist. We have actually more dermatologists in Palm Beach County than in the entire state of Georgia. So it's a densely populated world of dermatologists here in Florida. So as a patient, you can literally just call up the dermatologist and make an appointment and go in and get a skin check. And if something is found suspicious, you're sort of on that pathway. Whereas, having my wife is Canadian and we certainly have family in Canada. So I'm aware there's some differences in terms of getting diagnosed. May go through the primary care physician a little bit more. There may be some referrals involved before you kind of get to a dermatologist or the specialist who's going to manage that cancer. But certainly in terms of broad strokes of managing skin cancer, I mean, let's just kind of break it down real quick. You've got basal cell cancer and squamous cell cancer. Those are what are called your non-melanoma skin cancers. And those are by far and away the majority of what we see. I mean, probably 95% of the skin cancers that I'm seeing and treating are those types of cancers. And then you would have, obviously melanoma, skin cancer, and now more to agree, we're seeing a little bit more of what's called Merkel cell carcinoma, Merkel cell cancer. And unfortunately, that's what Jimmy Buffett passed away from. And so that's getting a little bit more publicity, and certainly the rates of that are on the rise. And that is a sun-related skin cancer as well. So I think we'll focus maybe first on just, you've been diagnosed with basal cell or squamous cell carcinoma. What happens next? Well, that diagnosis has to happen with a biopsy, and that maybe is that your dermatologist or even a primary care doctor, maybe up in Canada. And then, the question is, well, how are you going to treat this? And there's a variety of options. I mean, some superficial skin cancers could certainly be treated topically with the chemotherapy cream. Certainly some squamous cell cancer, if it's an in situ, meaning it's just in the very top layer of the skin, in a cosmetically sensitive area. I mean, the biopsy is removing a lot of that. And many of those patients may do fine with, a several week course of a topical fluorouracil cream. So that's certainly something that I offer patients a lot. They come to my office thinking they're going to have surgery, and I say, you know what? This looks really good. Why don't you just put a cream on it for a few weeks? And they always kind of breathe a sigh of relief, being like, oh, we don't have to cut this one out. And I'm going, no, we don't. You don't have to cut that out. So that's always a good question to kind of ask your doctor is, is this something that we can maybe not cut? Maybe we can put a topical cream on it. Obviously not every cancer is going to be amenable to that. And so then we think about, well, maybe if it's in an area that's not all that cosmetically sensitive, it's just on a guy's back and he doesn't want an incision, maybe we just can scrape it off and cauterize it a little bit. And that, has a very high cure rate as well. Probably don't want to do that if it's, on your nose or on your forehead, but, for some areas, where maybe there's a lot of tension on the skin and you don't want to do a big excision and tell the guy, oh, now you can't exercise for, 2 to 4 weeks. They're going to say, well, okay, isn't there a simpler option here? So that's certainly another option too. And then we talked about, you guys mentioned an excision, cutting the cancer out versus doing, what I often do, which is called Mohs micrographic surgery. But I explain patients and I say, really, all we're doing is I'm cutting it out. It is an excision. The only difference between, a standard excision and a Mohs procedure is sort of, one, how the tissue that's removed is processed. When you just cut it out and you send it off to pathology in the hospital, they're gonna bread loaf the specimen. They're gonna cut it like a loaf of bread, and then the pathologist is gonna look at each one of those sections. And if at the edge of those sections they don't see any cancer cells, they're gonna say it's all clear. The problem with that technique is that really when they look at those sections, they've really only looked at about 1% of the actual true margin of the cancer. So you could be seeing a clear margin, but maybe they're not seeing the full picture. So when you do a Mohs, the way the tissue is processed, we call it en face, which means you kind of take it, it looks like a Reese's peanut butter cup, and you smush it flat. And then in a single view, you can see the entire edge and the entire depth of the cancer. So that really gets you a very accurate picture of what you just took off of the patient. And you can see very accurately, did you remove all the cancer? And if not, you've kind of mapped out this specimen like a little clock face, and you can say, well, there's cancer still at 2 or 3 o'clock, or maybe it's over at 6 o'clock. So I'm going to go and take a little bit more and we're going to test it again. So it's really a very accurate way to remove skin cancers. This technique has been done for decades. It's not a new thing. We've been doing it for, 60, 70 years. And we've really got it dialed in. So it can produce very high cure rates. And you really only have to cut and take out what's necessary to get a clear margin. And I will say the one thing that's kind of worth mentioning with the technique too is that, a lot of times patients may get a biopsy report, and it's kind of indicating, a certain type of basal cell cancer, certain type of squamous cell. And when we get in there in Mohs, we might see something a little different, a different type of skin cancer. We might have a different pathology pattern. And so it kind of allows us to read and react in real time, give that information to patients, and then kind of adjust the treatment as we go. That's a little bit about Mohs surgery. And again, that's done typically for basal and squamous cell cancer. People are now doing it more for melanoma in this country as well. So that's a good thing to ask about. But a lot of those Mohs for melanoma need some special immunostains in the lab. And it's a little bit more of a time-consuming process. So it's not something that's done everywhere. It's typically done at academic centers or higher volume centers. We're currently not doing it in our practice. I refer a lot of those patients down to University of Miami. They've got a great team there. They've got a great process there. So, if someone gets a melanoma in situ on their nose and they want Mohs for that, they can go down to UM and have that treated.
Yeah, we do have some Mohs surgeons in Southern Ontario, but it is kind of a rare breed, right? It's hard to find. So there's definitely not the same availability.
Well, it's funny because you just trained one at a University of Toronto, and she took a job with our practice. So I'm not kidding. When you lost them to Florida, I was just looking. We just hired a new Mohs surgeon in our Stewart office, and she just finished her fellowship at U of T. And I said, I thought to myself, I said, gosh, I thought, they probably aren't training that many Mohs surgeons in Toronto. How'd they let this one go?
It's hard to hold on. When you're competing with Florida, it's hard to hold on. Yeah. There's some different reasons for that.
There's a lot of prosperity in Florida right now. So,
I mean, it's fantastic. I think, one of the things that I've struggled with over the years is some of these patients, some of these patients who are just like factories of skin cancers, right? So, fair-skinned person getting a bit older, and they're just coming back to see every couple of months with cancer after cancer. So, and I know there have been some studies that have shown there are some medications you can take. I think some vitamins and things like that. Where do things stand with that? Like, are there any like standard supplements you give to your kind of high volume patients that keep coming back and back with all these skin cancers?
So I think we're going to look at what things we can control here. So certainly, they always say, it's never too late to wear sunscreen. So, and they have studied this. So even if you have a lot of skin cancers, don't give up on the sunscreen, keep up with the sun protection. That is an important part of it. You also want to be supplementing with a vitamin B3, which is called niacinamide. We have all of our high-risk skin cancer patients taking 500 milligrams twice a day of niacinamide, and there's some good studies that show that does offer some small benefit, in these patients who are just covered in typically in actinic keratosis, which is kind of the precursor or precancerous lesion of a squamous cell cancer, and then squamous cell cancers as well. For really high-risk patients who may have had an organ transplant, or they have chronic lymphocytic leukemia, and patients who are making, more than, we might say the threshold is somewhere around maybe 10 skin cancers a year. If you're making at least 10 a year, you should at least consider going on an oral medication called acitretin, which goes under the brand name Soriatane. And then that can be kind of titrated and dosed in a way to kind of minimize side effects and hopefully try to cut down on some of these skin cancers. We try to get all our organ transplant patients on sort of the newer generation immunosuppressants. So things like tacrolimus, mycophenolate, as opposed to cyclosporin or azathioprine. Those older agents make patients very susceptible to squamous cell cancer. And then we try to work too. I mean, if you really have a tough patient, there's some medical therapies. We work with oncology. Libtayo is a new medicine that's approved down in this country. Cemiplimab, I believe, is the generic name of that, and that can be used in locally advanced squamous cell cancer. I've had patients even with just multiple hard to treat squamous cells, and they can go on infusions of that every several weeks. Keytruda is another kind of an immunomodulator, I guess I would say, that you use to kind of boost the immune system and fight off these multiple recurrent squames or metastatic squames. So there's some tools that the oncologists have, and it's always good to in these advanced patients, get oncology involved. We also have for metastatic or locally advanced basal cell, you have Odomzo and Eravige are the two oral therapies for basal cell. And it's probably worth just briefly touching even on radiation, which is certainly a big thing. Again, I'm not sure how much radiation they're doing in Canada.
Kind of come online even since we were in medical school, right?
I think there's some financial incentives behind it that may be kind of fueling the rise of it a little bit. And so to kind of just speak broadly, I mean, radiation is approved for the treatment of skin cancer. And then within radiation, there's actually many different types of radiation. I'm not a radiation oncologist, but I work closely with a lot of radiation oncologists. So this is, again, just kind of what I've picked up through my practice over the last 10 years or so. But, a lot of dermatologists in the United States are offering in-office radiation treatment, something called superficial radiation therapy. So it's good to know about. There's certainly a lot of advertising around this because, again, it's done in the dermatologist's office. And there's a big company down here called Gentle Cure. That's a private equity-backed company that does a very strong advertising efforts to try and get patients in the door. But there's some questions about how that's done, how they're billing. They're using an ultrasound probe to kind of look at the tumor, and then they're billing this as a complex image simulation of the skin cancer, which sort of implies a little bit more work. I mean, when that code was designed, I think it was designed for using a CAT scan or some hospital-based equipment. There's obviously a lot of controversy around this, and some codes and reimbursements have been cut, and so I always tell patients, my personal advice is if you're going to get radiation from your skin cancer, I would go see a board-certified radiation oncologist to get those treatments. And I don't think I would necessarily let a dermatologist administer those radiation treatments. Again, it's not something that dermatologists are trained on really at all in residency programs. And so this is stuff that, they've picked up post-residency through either training courses or whatnot, or through the company that's selling them the machine. A lot of times they kind of have a financial interest in getting patients to do the radiation because of the cost of it. A lot of times patients have to go for 20 or 30 sessions. So, I always say, you want to ask the right questions. If you're being offered radiation, you want to know, is this being administered by a board-certified radiation oncologist or dermatologist? And then certainly, the radiation oncologists typically aren't the ones doing superficial radiation. They're doing things like electron beam therapy, high-dose rate brachytherapy, intensity modulated radiation therapy, proton therapy. So there's a lot of things that they have in their toolkit that are typically done in hospital settings or a clinic where they have some pretty serious equipment to do that, and they can get excellent results with that. So I frequently, if we have a patient coming in with a cancer that's going to leave a pretty significant cosmetic defect, it's a large nasal cancer, large cancer on the ear, we always make sure to have that conversation and say, hey, listen, surgery is one option. This is what you can anticipate, but there is a non-surgical option, and they can get some excellent results. So we definitely work closely with radiation colleagues and get patients involved. But again, I think it's important to kind of know who's doing the radiation for you.
So would you say that for cases where surgery may not really be possible or may result in a really bad cosmetic problem, the second, well, maybe the next choice might be radiation as opposed to some of these, we talked about some of these chemotherapeutic agents?
I think a lot of these chemos don't really necessarily have It's more for disease control, and it may not be a full-on cure. Where I think, when you're referring a patient to radiation for a localized cancer, the expectation is you will cure that cancer. So I think it's, typically we're not moving on to these other therapeutics unless they've kind of failed surgery, failed radiation, or it's it's now metastatic. They have nodal disease from a squamous cell, metastatic disease from a squamous cell. So I've seen beautiful work from the radiation guys. I mean, again, if you're working with a good radiation oncologist and they can do 3-dimensional modeling of the site using a CAT scan, I've seen some tremendous results of patients. Patients 80 years old and they don't want, they want to live out the rest of their days with their nose intact. They don't necessarily want their whole nasal ala removed. And, a big, I had this conversation the other day, he said, well, if we do Mohs, you're going to need cartilage graft, forehead flap, going down the list of how we're going to have to rebuild this nose. And you could see the patient was not excited about this in the least. So, then we said, well, you can go over and have this, CT simulated radiation therapy, and they don't even have this done. She was kind of like, well, let me go down that route. So these are definitely options here. I'm not familiar with how necessarily how that works up in Canada with some of these things.
Yeah, thankfully that is well available in Canada. So radiation is very available, particularly like in like metropolitan areas and stuff. So I think we're pretty consistent in terms of being able to offer that to patients in certain situations for sure. So that's good. But I will say that's very interesting in terms of the some of the other modalities that are like, we definitely have people that kind of hanging out their shingle and offering different therapies in Canada. Things are a little bit. We hear about Florida and we often say, oh, that's in Florida and that's not happening here. But it's amazing how little regulation some things can have in Canada as well. So I'm sure if it's not here yet, I'm sure it'll be here soon enough. So those are very good to know about, to hear kind of what's happening at the cutting edge there. So
in terms of for people who are kind of worried about having a skin cancer, I know that there's these different diagnostic tests available now to people. And you'd mentioned just an encounter you had with a surgeon friend of yours, or your...
It's definitely worth talking about some of the new molecular diagnostics that are available, just in terms of giving some prognosis on things. I think we did a good job kind of touching on basal cell cancer, squamous cell cancer. Obviously, melanoma is a cancer people worry a lot about. Very serious diagnosis, a skin cancer that certainly has the potential to spread, to be lethal, may even be affecting younger patients a little bit more, depending on their family history and things. So that is something that obviously scares a lot of patients, getting the diagnosis of melanoma. And so the question is, okay, you went to your dermatologist, they did a biopsy, and they're going to come back and they're going to tell you, oh, you've been diagnosed with a melanoma. What's my prognosis? What's going to happen? And traditionally, the way that was managed was the pathologist was looking under the microscope when the doctor did the biopsy, and looking under the microscope, and they're measuring a very small amount of tissue, and they're giving you a number called the Breslow thickness of that melanoma. So they're measuring, when they look under the microscope, how thick that melanoma is. And so they may say, well, that melanoma is 0.8 millimeters in thickness, or they might say it's 1.2 millimeters in thickness. So you can get a sense. I mean, that's a very small, number. And so I'll share this funny story, which I was skiing last winter, and it was after the after the day of skiing, I'm sitting there, I'm warming up in the sauna, and these two guys are next to me, and I hear them talking, and the guy's going, well, my doctor, he called me and he said it's 0.8 millimeters. And we want you to have a lymph node biopsy with that number. And he looks at his friend and he goes, but I mean, 0.8, I mean, what if they measured it and it was, 0.7, and then the cutoff is 0.8, like maybe I don't need to send a lymph node biopsy. And he was raising a good point, which is that, with any measurement, there's an inherent error to that measurement. And certainly when the pathologist is looking at the biopsy, the diagnostic specimen, they're only looking at a portion of that cancer that was biopsied. And the biopsy only represents a portion of the cancer. So it's a valid question. Turned out that these two guys were physicians themselves. They're orthopedic surgeons, and so they had some knowledge of what of this concept of maybe there's some error involved in this. And so I was thinking to myself, I have to chime in here. I have to offer my 2 cents, because I feel like there's a piece of information that could be very helpful to this guy and has not been given by his doctor. So there is a test that's offered by a company called Castle Biosciences, and it is a gene expression test. And it basically will test the gene profile of your melanoma, and then it will risk stratify that melanoma, and it will kind of give you a much more granular look at what is the true risk of having positive sentinel lymph node biopsy. And so you can order this test, and if it comes back as a low risk melanoma, then you can rest assured that the risk of doing that sentinel lymph node biopsy, it's probably not worth it. You're sort of in that low risk category. So I had to mention that this test, and I said, "Did your doctor tell you about this test?" And he goes, "No, my doctor did not know there was this test." So I was like, "Listen, if you go and get this test and it comes back and it shows you're low risk, then I think you can kind of say, well, it was a borderline thing, and I don't need to go and have lymph nodes cut out, and we'll just monitor things." Whereas if it comes back and it's showing a more intermediate or advanced or higher risk melanoma, then I think you want to kind of take the necessary steps going down that way. So that is something that's now available, and certainly something patients should be asking about if they have the diagnosis of melanoma. Is the doctor should be looking at the gene expressions of these tumors.
Is that something they can ask? Is that something they can get themselves, or do they have to go through a doctor to get this test?
I do believe the doctor has to order it. It is something that I'll sign off on for patients. But it is available. it's out there. I know that it is covered by insurance. Patients are not getting surprise bills from this thing. So it is something, if you receive the diagnosis of melanoma, you definitely want to make sure you kind of understand the risk level you're at, in addition to that number that they're always giving you, which is the Breslow.
I think that's super useful. That's very useful, because there is there's risks and benefits to everything, and getting lymph nodes sampled, there are risks associated with that. So that's super helpful.
And as an aside, they also the same company makes a similar test for high risk squamous cell cancer. So again, if patients are diagnosed, they have an aggressive squamous cell cancer. If that's something I see under the microscope, I see the cancer's involving a nerve, or maybe it's a larger, deeper tumor, and we're really worried about this tumor. And now we can kind of look at the genetic signature of that squamous cell, and we can say, well, listen, maybe this is a patient who, it was a really bad cancer. Even though we got a clear margin with Mohs, there's still someone who's at risk of having nodal disease or metastatic disease. So they're going to be referred for what we call adjuvant radiation therapy. So even though we got a clear margin on Mohs, we're going to send them over to the radiation team, and we're going to have them, do some adjuvant radiation to the area, just to really minimize their risk of having a MET or recurrence or something like that. So, and again, most of those are coming back low risk, and they're not getting sent out, for adjuvant RT, but it really does, again, help risk stratify patients and figure out who can benefit here.
That's incredible. Wow, that's definitely something we'll have to think about for our patients too, Mark.
Absolutely. No, that's great. Because there's obvious ones like the perineural involvement and all those. Like, sure, we send them for radiation, but I think having this available now will be wonderful. And I think generally speaking, in Ontario, we are able to access something that's so impactful. So I think if it's not here already, it will be here soon, and we'll definitely incorporate that.
Yeah. How long have you been using these different tests in your practice?
It's been a couple of years now that we've had these available.
That's very cool.
Future is bright.
It's been a wonderful conversation for us, Dr. Spock. It's always fascinating spending some time with you, and I really enjoyed it.
Yeah, illuminating.
Thanks for having me on, guys. Yeah, I really enjoyed it. Really enjoyed it. We'll have to catch up in person when I'm up in Canada.
Sounds great. That's perfect. Okay, take care.